And when we talked last semester about the biomechanics of the wrist and looking at the scaphoid likes to sit in about a 45-degree flexed position, okay? So we already know the angulation of the scaphoid. So what we're going to do is to determine if there's any issue between the scapholunate ligament and if there's a disruption there. This test will really be able to tell us, depending on how much the scaphoid wants to move, if there is a problem there and if we need to be getting a hold of a doctor and a surgeon and saying, hey, I might have a prospective patient for you. So to be able to do this test, what you want to do is be able to have the patient, if I may have you turn just a tad bit, and I want to have their elbow on the table. I want them supported, and sometimes if it's going to be a hard table, I'm going to sit there and get a couple towels underneath them. I want it comfortable because I'm going to be putting some pressure right through the forearm here from the top of the hand. And what you want to start with is, so the scaphoid, the tuberosity of the scaphoid is going to become very prominent when you go into ulnar deviation. It'll be very easy to find. So if you guys want to just be able to move your wrist back and forth, you'll kind of feel how that, you can feel the scaphoid and the tuberosity of it right there at the base of the thumb. Yeah, well, or you have to pop quite a bit. And we'll start with this test where I'm applying pressure dorsally. So from the volar aspect, I am putting pressure in against the scaphoid, because what is the scaphoid going to want to do? It's going to want to flex right down into my hand. And if I start in ulnar deviation, I'll explain this as I go through it a couple times here, is I'm going to get a hold of that tuberosity. I'm going to start with her wrist in ulnar deviation and slight extension. And as I hold onto that scaphoid tuberosity and apply force, so I'm not going to let it want to try to come into my, like it naturally wants to do, it wants to flex. As I radially deviate her wrist and flex, I'm even going to feel the pressure of that scaphoid more into my thumb. But if there was an issue with the ligament being ruptured, all of a sudden her scaphoid would want to clunk, because the pressure I'm applying will actually want to cause it to go dorsally. Does that make sense? Mm-hmm. So you'll get, and it is, and they just, patients will describe it, and that's why it's in literature written as clunk. I mean, great term, right? But it really feels like, I mean, it'll just drop, and patients will feel oftentimes pain-provoking, but more than anything, you're feeling for that clunked. So again, you don't want to have their arm out here and applying pressure. You really want to be able to get that hand right over the top, right over the elbow. Feel for the scaphoid tuberosity. Ulnarly deviate, slight extension. Bring them in, and I'm not putting too much of an axial load with this hand down towards the table, as much as I'm just stabilizing everything. As I go into radial deviation, slight flexion, and I'm feeling her scaphoid really press against my thumb. I'm not feeling it give out. But if there was an issue there, all of a sudden I would feel that clunk. I would feel that scaphoid shift dorsally.
Is that the catch-up clunk that's mentioned in the article?
What's that?
Is that called the catch-up clunk that's mentioned in the article, or is that some other injury?
That, I apologize, I do not know for sure. I'd have to take a look at it. Let me check on that for you. But the clunk is